This is Dr.Sepuri Krishna Mohan, Endocrinologist, Sepuri Diabetes and Endocrine Center, Kurnool. Very good evening, my dear professional colleagues, and thanks to Boehringer Ingelheim for inviting me as speaker this evening. So today we are going to talk about the empowering holistic clinical approach in type 2 diabetes mellitus with atherosclerotic cardiovascular disease, that is ASCVD. You can see in this slide the thin fat Indian phenotype and the premature cardiometabolic risk, the high dysmetabolic adiposity and the insulin resistance. The characteristics of new onset type 2 diabetes in India are totally different from that of UK. The patients from India they are diagnosed at an younger age, that is at least 10 years younger than the UK and other the western part of the world, and they have less generalized obesity and thinner limbs but higher adiposity, and they have higher central adiposity, and they have got more insulin resistance, which is measured by HOMA, that is the homeostasis model assistance. And on the right side you can see the bar diagram which shows the down bars and the top bars. So you can see the age diagnosis, the newly diagnosed type 2 diabetes. This is the Indian scenario versus the UK whites actually. So the age diagnosis is at least in our scenario, Indian scenario, the diabetes is diagnosed at least 10 years prior to that of the UK whites. And when you consider this body mass index also, it is in males it is 4 kilograms per less than by 4 kilograms per meter square, and in females 6 kilograms per meter square, and the mid-arm circumference is less by 20%. And when you come to this WHR, that is waist hip ratio, it is 5% excess when compared to the Britishers, and the subscapular and the triceps ratio is excess by 20% in Indians, and the fat percent is excess by 30% in Indians when compared to the Britishers, and at the same time the insulin resistance is at least 1.5 times more than that of the UK people. And this slide shows about the insulin resistance and how it predisposes, like insulin resistance, how it predisposes to the early onset of the atherosclerotic cardiovascular disease. See, insulin resistance per se, that is that leads to hyperglycemia, and that leads to vascular proliferation, which lead to atherogenic dyslipidemia, which in turn that leads to premature atherosclerosis, and added to that like comorbidities like hypertension, and this particularly the diabetes and put together this hypertension, they lead to the macrovascular complications as well as the microvascular complications or the dysfunction. And this slide shows the prevalence of cardiorenal metabolic comorbidities in type 2 diabetes mellitus, and you can see the different complications what we see, like okay, we take cardiac autonomic neuropathy is 20% more when compared to the western scenario, that is 1 in 5 people they have cardiac autonomic neuropathy. When you take the non-alcoholic fatty liver disease, which is with the clinical relevant fibrosis, so that is by 23.7% it is more seen in Indians, and that is 1 in 4 have this NAFLD with liver fibrosis. And when you take this cardiovascular disease, it is more by 32.2%. So that is 1 in 3 have cardiovascular disease in the Indian scenario. And when you take this left ventricular diastolic dysfunction LVDD, this is excess by 46%. So that is 1 in 2 have, almost every 1 in 2 have this left ventricular diastolic dysfunction. And when you take this chronic kidney disease, it is the incidence is 48%, that is almost half. 1 in 2 have chronic kidney disease. And when you take this obstructive sleep apnea, it is by 71%, and this is 2 in 3 have obstructive sleep apnea in our scenario. These are all the cardiorenal metabolic comorbidities what we generally see in type 2 diabetes mellitus. And when you come to the subclinical coronary artery disease in South Asian people with type 2 diabetes, when you compare this with the Caucasians, that is the whites, you can see this on the CT angiogram based findings in the asymptomatic people with type 2 diabetes mellitus. When you take this, the coronary atherosclerosis, so when you compare this with the CAC, that is coronary artery calcium, which is positive, it is 66% in South Asians, and when compared to the Caucasians, it is only 53%. So it is excess by 13% in South Indians, and around or more than 50% stenosis in a coronary segment is 41% in South Asians, whereas it is only 28% in Caucasians. So that shows that the cardiovascular disease is much prevalent in the Indian scenario, especially the Southeast Asia, that is our Indian scenario. And the inference is 2 out of 3 may have coronary atherosclerosis, that is 66%, and 2 out of 5, that is 41%, may have clinically relevant coronary artery disease. And this slide shows the recommendations for the usage of the laboratory and the electrocardiogram and imaging testing for cardiovascular risk assessment in asymptomatic patients with diabetes. And you find in the right hand side the class of recommendation and the level of evidence. These are the two evidences what we have according to the international nomenclature. The COR is called the class of recommendation, and the level of evidence is, that is where the level of evidence is mentioned in A, B, C, D, and E, that is expert opinion, whereas the class of recommendation is always indicated in the Roman numbers like 1A, 1B, 2A, 2B, 3A, 3B, 4A, 4B. So 1 is the highest as well as the class of recommendation is concerned, and A is the highest when compared with the level of evidence. So you can just go through this. The routine assessment of the microalbuminuria is indicated to identify the patients at risk of developing renal dysfunction or at the high risk of future CVD. It comes under the class of recommendation is 1 and the level of evidence is B. So a resting electrocardiogram is indicated in patients with diabetes diagnosed with hypertension and with suspected cardiovascular disease. The class of recommendation is 1, and again the level of evidence is C. And when you take the assessment of carotid and the femoral plaque, and you can just go through this. These are all 2A, 2B, 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 and it is all the level of evidence is B. And going to the next slide. So let us take a prototype Indian patient with type 2 diabetes mellitus and subclinical coronary artery disease. And the clinical presentation is a 48-year-old male non-smoker, known case of type 2 diabetes for 2 years, hypertension for the last 10 years. Father had history of myocardial infarction at the age of 55 years. His body mass index is 27.2 kilograms per meter square, and the waist circumference is 95. So he's got the comorbidities like hypertension along with diabetes, and he's got a strong family history of myocardial infarction. According to our Indian guidelines, he comes under the classification of obesity. Actually 27 plus is obese, and according to the Western the international classification, he falls under the category of overweight. And coming to waist circumference, see the normal waist circumference for a male is 94 centimeters is good, and 80 centimeters in females is good. It is 95 centimeters, not a problem. and the clinic blood pressure is 130 bar 84 millimeters of mercury. That's not a problem, but okay. The systolic is okay. The diastolic is the excess by 4 milligrams per mercury. And the medication he is receiving is taking metformin 1.5 gram per day, and tablet telmisartan plus amlodipine 40 mg and 10 mg of amlodipine once a day, and he is taking atorvastatin 20 mg once a day. And the workup we did is the glycosylated hemoglobin HbA1c is 8.2%, and the fasting plasma glucose is 134, which are on the higher side. And the total cholesterol is 189 milligram per deciliter. It's okay, but LDLC is 114 milligrams per deciliter, which is definitely on the higher side. HDL is 40 milligram per deciliter according to this international guidelines and the guidelines of the American Diabetes Association. It is normal for males. For females, it should be above 50 milligrams per deciliter. And triglycerides are marginally high. It normally is less than 150, around or less than 150. It is 164 milligrams per deciliter. And the urine albumin creatinine ratio is 90 milligram per the gram creatinine. That is, he's got microalbuminuria, because below 30 it is normal, and above and until from 30 to 300 it is we say it is microalbuminuria, and beyond 300 we say it is macroalbuminuria. And now the latest terminology for microalbuminuria is the urine albumin creatinine ratio from this 2021 ADA guidelines. And the serum creatinine is 1 milligram per deciliter normal, but every time I mind you, please calculate the estimated glomerular filtration rate. So then only you will be able to stage the kidney disease. So the best method is the CKD EPI modified 2009 is the best one. So according to that, the estimated glomerular filtration rate will be 89 milliliters per minute per 1.73 meter square of body surface. And liver function, no abnormality detected, and fundoscopy also shows no abnormality, and the recent treadmill test was positive for inducible ischemia. And now we are coming to the main topic of this particular empagliflozin actually. So now I am into this particular the gliflozins actually. So I would like to brief you about the gliflozins actually. The SGLT2 inhibitors are the latest drugs in the armamentarium of in the treatment of type 2 diabetes, which are otherwise known as the gliflozins. The currently available the gliflozins approved by the US FDA are the empagliflozin and the dapagliflozin and the canagliflozin, which are readily available in the country for the last few years. And there are other gliflozins also, like okay, we have got Indian gliflozin called remogliflozin that needs a lot of cardiovascular outcome trials. Okay, so coming to the ones that are not available in India are the etogliflozin, which is there but it is not available in India, and the sotagliflozin is there. These are all SGLT2 inhibitors. The speciality of the sotagliflozin is that inhibits SGLT1 receptors as well as the SGLT2 receptors. So that is the wonderful drug sotagliflozin. And ipragliflozin and bipragliflozin. There are so many gliflozins in the pipeline, and the currently available is only empagliflozin, followed by the DAPA, and followed by the CANA. And I mind you once again, the SGLT2 inhibition is maximum with empagliflozin, and the least is seen with the canagliflozin, and in the middle there is dapagliflozin. The more the SGLT2 inhibition, the more the reductions in the blood pressure, blood sugars, and even the glycosylated hemoglobin. So these are the new drugs which act through kidneys, because SGLT2 inhibitors are present in the proximal convoluted tubules, and the SGLT1 receptors present in the proximal straight tubules. So this is the juxtaglomerular apparatus. You all know that, okay? The descending loop and the ascending loop of Henle, and the convoluted tubules and all. So the mechanism of action, how this the SGLT2 inhibitors act is they act by inhibiting the SGLT2 receptors, and that leads to the very much reduced reuptake of the glucose from the urine. So glucose is being excreted through urine when you take this particular SGLT2 inhibitor, either empagliflozin or canagliflozin or dapagliflozin. So on an average, from 80 grams to 120 grams of glucose is being excreted in 24 hours. The patients who are on this SGLT2 inhibitors. That is the reason it has got the greatest advantage of the weight reduction, because every day around 80 to 120 grams of glucose is being excreted from the body. And I would like to just summarize the basic beneficial effects of this particular gliflozins. The SGLT2 inhibitors are otherwise called gliflozins because everything ends with the empagliflozin, canagliflozin, dapagliflozin. So they emerged as the anti-diabetic drugs for type 2 diabetes actually. So to start with, they started as a glucose lowering drugs. The endocrine domain started using it, and it's a wonderful the drugs of the treatment for type 2 diabetes. And the additional benefits are the reduction in the weight to a tune of 3 to 6 kilos, and because of the glucose excretion and all, and the osmotic diuresis effect which is seen with the SGLT2 inhibitors. And at the same time, we find the beneficial effects on the blood pressure, because systolic blood pressure is very significantly reduced by empagliflozin. That is very much proved by SACRA study. That is all evidence based this thing. And the average systolic blood pressure is around 10 milligrams of mercury plus or minus 1 to mm of mercury. And latron, this particular molecule, had shown other effects, like it started showing reductions in the hyperuricemia, which was a favorable effect in the patients suffering from gout. Actually, most of the type 2 diabetes patients, they do suffer from hyperuricemia. So this empagliflozin reduces this particular thing, and empagliflozin is backed up by the lot of evidence, like to start with it is EMPA-REG and then EMPA-REG outcome, and this particular EMPA heart, and the next emperor reduced and the emperor preserved, and the EMPA kidney, and so on and so on. It goes like anything, and it has got a lot of the evidence based medicine. And later on it emerged as per the EMPA-REG outcome trial. Later on we saw that it has got the cardiovascular benefits, like it is got wonderful effects in reducing the incidence of 3-point MACE, and regarding heart failure, and regarding the hospitalization heart failure, and the incidence of strokes are very much reduced with empagliflozin. And later on it showed beneficial effects on the kidney with the progression of this thing is the proteinuria is very much minimized, and it reverses that albuminuria. And later on it showed the beneficial effects on the liver also, like the NAFLD and the NASH. The reversal of fibrosis was seen, the reversal of the fat conversion was seen, and the liver was absolutely safe in the patients who used this particular empagliflozin. And off late, last month, the journal, the circulation has published an article saying that this particular empagliflozin has got the effect on the reduced incidence of cardiac autonomic neuropathy, that is CAN, and as well as the reductions in the vasovagal syncope, and the most beneficial effect is seen with this reduced incidence of the obstructive sleep apnea with empagliflozin. So these are the greatest advantages. So I call this wonderful drug as a pleiotropic drug first of all. So it is available in the 10 milligram and 25 milligram, but all the studies are done with the 25 milligram. No study is done with 10 milligram. So I would like to request all the participants to use only 25 milligrams of empagliflozin. That is, the brand name is Jardiance. The original manufacturers are the Boehringer Ingelheim. And I mind you at the same time, these are the indications and the advantages. And where it is not to be used, I have to highlight, because these company people will not highlight where it should not be used. See, it should not be used in patients who are already dehydrated, because this causes osmotic diuresis, leads to dehydration and dysalkyltemia. So this is one condition where you have to stop this particular one. This is confined to only for the treatment of type 2 diabetes mellitus as of in our country, whereas the European Union, they are using this empagliflozin, the dapagliflozin and the canagliflozin in type 1 also, which has resulted in very much reduced doses of insulin in patients suffering from type 1 diabetes mellitus. And second thing is, you must be very cautious about the genitourinary tract infections and the urinary tract infections, that is the UTIs or the candidial vasinitis, that is the candidial vulvovasinitis, or the candidiasis, that is balanitis or fasciitis or balanopasciitis in the males, or the candidial vulvovasinitis in the females, which is seen in patients using this particular the gliflozins. So it is contraindicated in patients with repeated genitourinary infections and repeated the candidiasis infections. So barring these, if you can advise the patient to take plenty of fluids, that is water, lemon water, and the ragi ganji and the buttermilk and all, if the patient is adequately hydrated, you don't have any problem with this. So with the introduction, I just get into this. And empagliflozin strongly improves the glycemic control in comparison to sitagliptin in type 2 diabetes. So they have a comparative, they have compared this particular the empagliflozin with sitagliptin 100 milligram, and the empagliflozin was 25 milligram, and you can see the bar diagrams, and the green is empagliflozin and the orange is the sitagliptin. The baseline HbA1c was 8 and the reductions was with EMPA it is 0.87% reduction in the A1C, and with sitagliptin it is 0.71 reduction, and with the baseline of HbA1c of 9 it is 1.36% reduction in with the patients on empagliflozin, and with the sita it is reduction by 1% of HbA1c, whereas the baseline of HbA1c of 10 the empagliflozin 25 reduced HbA1c by 1.85%, and whereas this sitagliptin reduced by 1.28. That means the higher the HbA1c, the more the reductions that is seen with the empagliflozin. That is a characteristic feature of gliflozins as well as the DPP4 inhibitors. And I mind you at this particular juncture, that is the A1C is lower, the reductions are lower. A1C is higher, the reductions are higher. And the very characteristic feature, the take home message, everybody should mind this particular point, that the SGLT2 inhibition is maximum in the Asian continent, that especially the Southeast Asian continent. So is with the DPP4 inhibitors. When compared to the Caucasians and the whites and the Westerners, the DPP4 inhibition as well as the SGLT2 inhibition is seen maximum with the Indian subcontinent especially, and other parts of Asia we see this phenomena. when compared to the Caucasians, where there is the reductions are little bit less when compared to the Asian subcontinent. So for every increase of 1% in baseline HbA1c, the corresponding HbA1c reductions at 24 weeks, there the empagliflozin with 25 milligram it is 0.49%, sitagliptin 100 milligram is 2.9%. That shows the significant increased efficacy with empagliflozin versus sitagliptin, where the p-value is less than 0.05, that is statistically significant. Though not very significant, it is statistically significant. So now come to the time in range. Nowadays, everybody is talking about time in range. TIR is very important. For the last couple of years, I think we have been listening to this time in range in India, but we have been used to this particular the time in range as well as the glycemic variability in the international conferences. We've been listening to that. See, the empagliflozin usage improves time in range, and with a 24-hour continuous glucose monitoring with empagliflozin versus placebo in type 2 diabetes patients, you can see on the first one is the placebo at the baseline day 1 and day 28, and the empagliflozin, the middle one is 10 milligram, same the baseline and the day 1 and day 28, and empagliflozin 25%, same day 1, the baseline and the day 1, and you can clearly see the red is the around or more than 180 milligrams of milligrams per the deciliter of the blood glucose is marked with red, and green is around 70 to 180, and the gray is less than 70. So that is hypoglycemia, and you typically see that the placebo, you can see the baseline is 47.9% is the time in range, and day 1 it is 43, and day 28 is 40%. So it is actually reduced. The time in range is reduced actually. So there are 3 points: time in range, time below the range, time above the range. So with empagliflozin 10 milligram, the baseline was 47.8, and on day 1 it is 34.2, and yeah, you need to consider the green one actually. So I'm sorry. So it is 52%, and it increased to 65.7%, and day 28 it was 77%. The time in range increased by 77. Like the empagliflozin, you take this particular the 25 milligram group, it was 55 to start with, and it went on to 70. The immediate next day, the time in range went up by around 15%, and at the end of 28 days, that is, it was 81%. So the p-value was from baseline it was 0.012. Now it is, the difference is the 0.001. That is the difference versus placebo in change from the baseline, which shows that it is statistically very, very significant. And empagliflozin therapy in insulin resistance associated disorders affects and promises beyond a diabetic stage. So the patient who is on empagliflozin, when he uses empagliflozin, we see all the benefits like the reduced anti-inflammatory M polarization, and the inflammatory cytokine, decreased inflammatory cytokines, and the decreased inflammatory chemotaxis are the chemicals, and the decreased T cell accumulation, and increased adiponectin, and increased energy expenditure, and increased fat burning, and the increased non-esterified fatty acid utilization, and the decreased NLRP3 expression. NLRP is nothing but not like receptor proteins. So, and the reduced mTOR pathway. mTOR pathway is nothing but the mammalian target of rapamycin. That is the pathway. And the reduced oxidative stress. These are all the benefits seen with this particular the empagliflozin. and that is the reason why I have said it's a pleiotropic drug, like statins, like metformin, and so this leads to reduced incidence of the insulin resistance, thereby it increases the insulin sensitivity, so it reduces the blood glucose levels, either the fasting or the post lunch or the HbA1c, which is called the glycemic triad. And these are all the other benefits. The empagliflozin lowers 4%. Empagliflozin lowers insulin resistance and inflammatory markers. Empagliflozin versus placebo in type 2 diabetes with high insulin resistance. You can see the differences in the HOMA-IR and the high sensitive CRP and remnant like cholesterol. High insulin resistance. And coming to this E-lift study, empagliflozin reduces the liver fat content in people with type 2 diabetes mellitus and in non-alcoholic fatty liver disease, that is the NAFLD and the NASH. So you can see in the bar diagrams which show that the baseline is the blue one, as and the orange is the post treatment with empagliflozin. You can clearly see this the control and the empagliflozin as a considerable reduction from 16.2 to 11.3% reductions in the liver fat reductions. So that is called E-lift study. That's what I have mentioned. So it is a wonderful drug to prevent the NAFLD and the NASH. And empagliflozin in non-alcoholic steatohepatitis, that is NASH, NAFLD and NASH, and type 2 diabetes, possible histological improvements in NASH at 6 months. So when you see the bar diagrams, the grey one is the particularly this one is with empagliflozin, and the white is the placebo actually. So when you take this particular steatosis improvement in NASH, it is the improvement is 67% with empagliflozin, whereas it is only 26 in placebo. Whereas the lobular inflammation improvement is 22% with this particular empagliflozin, and so also the hepatocellular ballooning improvement is 78% with that when compared to the placebo 34. So NASH resolution without worsening fibrosis, that is the prevention of the NASH to cirrhosis and the hepatocellular carcinoma, is by 44% when compared to the placebo, which is 22%, and the fibrosis improvement is 44% with this empagliflozin when compared to placebo, which is only 6%, and the fibrosis resolution is 38% with empagliflozin, whereas only 8% with the placebo. So this is the benefits of empagliflozin on liver. So now coming to the SACRA study, I have told you already the reductions in the blood pressure, especially the systolic blood pressure, and a minute reductions in the diastolic blood pressure also we see to a tune of 2 to 3 millimeters of mercury. So SGLT2 inhibition reduces systolic BP in older patients with type 2 diabetes and nocturnal uncontrolled hypertension. This is very, very important. See, this is important in two ways, that it very much controls the nocturnal uncontrolled hypertension and the daytime hypertension, as well as the morning BP and the 24 hours BP. With regards to, I am talking about systolic blood pressure only, not diastolic, because diastolic is not significant. Systolic is very significant. You can clearly see the reductions like the placebo is 2.8 and the empagliflozin, see, it is reduction of 11.5% millimeters of mercury, where the p value is 0.05, it is statistically significant. and the reductions. You can clearly see the morning home BP and the clinic BP. Wherever you see this particular empagliflozin group has a wonderful reduction in the systolic blood pressure. That too, it is very safe in the elderly, and you along with the standard treatment of hypertension for resistant hypertension, if you add this SCLD2 inhibitors, so you have much favorable effects with either the resistant hypertension or with the uncontrolled nocturnal hypertension. This is the take home message. This is the evidence based medicine I am talking about. This is because of the based on the SACRA study. Now we come to the SCAN study. Actually, the latest, that's what I said, the metabolism, that is the one of the world renowned journals actually, that last month itself an article was published saying that the usage of empagliflozin has reduced the cardiac autonomic neuropathy CAN outcomes in the patients suffering from type 2 diabetes mellitus. And the real world evidence in people with type 2 diabetes mellitus with vasovagal syncope, that is SCAN study. So both are reduced, the incidence of cardiac autonomic neuropathy as well as the vasovagal syncope is reduced with this particular thing. Thereby it prevents the majority of the deaths suffering from deaths related to heart actually. So now you see this the graph, you can very clearly see this. The blue one is non-SGLT2 users and the red one is the SGLT2 inhibitor users. You can clearly see the two graphs getting separated from the beginning, and at the end you can clearly see the widening of the curves showing the beneficial effects of the SGLT2 inhibitor users when compared to the non-SGLT2 inhibitor users. So you reduce the mortality rate, you reduce the cardiac autonomic neuropathy, you reduce the vasovagal syncope with this particular empagliflozin. And you can see this empagliflozin which decreases the risk of new onset obstructive sleep apnea. I have already mentioned based on the empiric outcome, empagliflozin versus placebo in patients with type 2 diabetes and the cardiovascular disease. That is the 52% reduction in the relative risk of new onset obstructive sleep apnea with empagliflozin versus placebo. Same thing, you can see the placebo in the black and the pooled empagliflozin in the red. You can see the curves getting separated and it is totally widened. There is so much of gap between the two curves at the end of the study. That clearly shows that empagliflozin reduces the risk of new onset obstructive sleep apnea. And coming to the empagliflozin results in 67% of lower risk of serious kidney events. This is very important beneficial effects of the empagliflozin. I have already mentioned the Scandinavian real world evidence, the empagliflozin versus DPP4 inhibitors in people with type 2 diabetes. So serious kidney events per 1000 patient years, and the green one is the empagliflozin and the black is the DPP4 inhibitors. And we can clearly see that the serious kidney events are only 2.1% that are seen with empagliflozin when compared to the DPP4 inhibitors. The incidence is 6.2%. So it has got favorable effects. It started as a the anti-diabetic medication, then it started as the cardiology drug, then it proved itself as a nephrology drug, then it proved as a liver benefit drug like the medical gastroenterologists. Everybody is claiming that this particular molecule belongs to our domain. And the greatest part of empagliflozin and the dapagliflozin is that the US FDA has clearly said that these two drugs can be used in cases of heart failure in patients suffering from type 2 diabetes mellitus or in the absence of diabetes itself. So this is the beneficial effect. So I request all the cardiologists to take up this particular molecule in the interest of the patient suffering from heart failure and the hospitalization of heart failure, which reduces the economical burden on the this particular the patient suffering from either type 2 diabetes or the patients with no diabetes also. The heart failure itself is a state of insulin resistance. So, say type 2 diabetes, most of the patients they land up in heart failure, and if you put them on this particular empagliflozin, the incidence goes down very drastically. So this slide shows the safety of empagliflozin in patients with type 2 diabetes and chronic kidney disease. It's a pooled analysis of placebo-controlled clinical trials. You can clearly see that the placebo and the empagliflozin, black is placebo and the empagliflozin is green. You can very clearly see the edema, that is 56% lower risk of in people with type 2 diabetes and the chronic kidney disease actually. That is stage 3B DKD or the stage 4 DKD. This thing, and so also the reductions in the incidence of hyperkalemia. See the 52% lower risk in people with type 2 diabetes in patients suffering from chronic kidney disease in either stage 3B or grade 3B or the stage 4 or grade 4. See, we divide this particular chronic kidney disease or diabetic kidney disease into 5 stages. Stage 1, stage 2, stage 3, A, B, stage 4 and stage 5. So, if you have the serum creatinine and if it is male or female and if it is either African American or others, you can calculate from, that's what I said, the CKD, the EPI CKD modified 2009 calculation. You can download it from the Play Store or this thing. You can put it in your mobile. You can calculate the estimated glomerular filtration rate, and the stages will be like anything above 120 ml per minute is normal, and from 90 to 120 is called stage 1. From 60 to 89 is called stage 2. From 45 to 59 is called stage 3 A, and from 30 to 45 is called stage 3B, and in between 15 and 29 it is called stage 4, and anything the EGFR of below 15 ml per minute per 1.73 meter square of body surface area is called the end stage renal disease stage 5 or end stage kidney disease. So according to KDIGO, this is the classification. So you can either call it stage 1 or grade 1. There nothing difference. They both are accepted by the international nomenclature. So these are the benefits. And the major studies with SGLT2 agents and the representative population by CKD risk, the KDIGO category, that's what I said. KDIGO is nothing but the kidney disease improving global outcomes actually. You can very clearly see that I have mentioned already. You can see on the right hand side the EMPA kidney and the credence done. The EMPA kidney is done with empagliflozin and the credence is done with canagliflozin, and the DAPA CKD is done with dapagliflozin. And here it is given on the left hand side. You can see that's what I said. The normal or high more than 90, it's above 120 is normal, and grade 2 is 60 to 89, grade 3A is 45 to 59, grade 3B is 30 to 44, and grade 4 is 15 to 25, and grade 5 is the less than 15. Okay. So the EMPA kidney trial stops early due to the evidence of efficacy. The USFD has seen the the EMPA kidney trials, the overwhelming response, the beneficial response towards the kidney benefits. So the US FDA asked these people, Boehringer people, to stop this EMPA kidney trial prematurely, seeing the wonderful results from this study, but yet the results are not yet published, and maybe in 2023 we get the results of EMPA kidney. Already we have got sufficient data from data CKD. The same thing happened to data CKD last year, and they stopped it prematurely. 6 months prior to that, US FDA said, seeing the wonderful kidney beneficial effects of this particular DAPA CKD, they said they asked them to stop this study prematurely. So the 16th March 2022, the EMPA kidney is the largest and the most inclusive SGLT2 inhibitor trial in chronic kidney disease to date. Okay. So far this is the landmark study when compared to all the studies done on kidney. So the trial's independent data monitoring committee recommended that the trial be stopped early due to the evidence that the trial treatment is more effective than the placebo, and the detailed results will be presented next year. And the EMPA kidney includes a broad spectrum of adults with CKD, which including people with mild to severely reduced estimated glomerular filtration rate, a measure of kidney function, and with normal and increased levels of albumin, a type of protein present in the urine, and with or without diabetes. That's what I said. So this is the greatest advantage of empagliflozin. This is the one drug, and along with that the second drug is dapagliflozin, which is been approved by US FDA to be used in patients suffering from heart failure, in diabetes or without diabetes. Same thing, seeing the benefits on the kidney, it said with diabetes, without diabetes, this can be used in cases of CKD, and with CKD attributable to a wide range of underlying causes, and many of these patients have been underrepresented in previous trials. And the SGLT2 inhibition and intermediate effects on pathophysiology of heart failure, the SGLT2 inhibition leads to the preload reduction, which increases the free water clearance, decreases the stressed blood volume, and decreases the pulmonary vascular pressures, and decreases the intraglomerular pressure. And the effects of myocardium we see are the increased metabolic efficiency, and increase in the diastolic relaxation, and increase in the oxygen demand supply balance, and decrease in the left ventricular hypertrophy. And the important is, the last one is very important, the reductions in the left ventricular remodeling. That is, the empagliflozin is going to reduce the left ventricular mass index. That is very important. So that prevents the heart failure actually. If you leave that, the patients will progress on to heart failure and fibrosis. And we have seen the preload reduction benefits and the effects on the myocardium, and the benefits on the afterload reduction, that is increased in the endothelial function, decreased in the vascular stiffness, and decreased incidence in the neurochromosomal stimulation, and increased in autonomic balance, which leads to all these things. They lead to an improved cardiac structure and function, thereby reduces the 3-point MACE and as well as the incidence of heart failure or the hospitalization for heart failure. Now coming to the empagliflozin, which improves the cardiovascular outcomes in type 2 diabetes with or without cardiovascular disease. This is the EMPRISE, the real world evidence, empagliflozin versus DPP4 inhibitors in patients suffering from type 2 diabetes. You can very clearly see the cardiovascular events. The green is empagliflozin, whereas the black is DPP4 inhibitors. You can clearly see that the hospitalization for heart failure, when you take this as a criteria, there is a reduction in the risk by 53%. So the empagliflozin is 3.6, whereas the DPP4 it is 7.9. And when you take this myocardial infarction, the same the incidence with empagliflozin is 7.3%, with DPP4 it is 8.6%, that is 13% decreased risk, and same all-cause mortality, it is 11% seen with empagliflozin, it is 19.6 with DPP4 inhibitors. That shows the 44% reduction in the risk of all-cause mortality and the patients who are on the empagliflozin, which is a point to be noted. And the empagliflozin has proven cardiovascular safety in type 2 diabetes across the cardiovascular risk spectrum. So you can very clearly see that the cardiovascular safety of empagliflozin, either the cardiovascular death or the hospitalization for the heart failure events. You can very clearly see that the CV death or the hospitalization for the heart failure, the DP4 is 8.2, whereas the empagliflozin is only 2.9%. So this is taken from this graph, is taken from the empiric outcome, that is the empagliflozin offers early risk reduction for cardiovascular death in patients with atherosclerotic cardiovascular disease and type 2 diabetes mellitus. And you on the right and left hand side you can see the overall population, and the right hand side you can see the Asian patients subgroup. That's what I said. So you find very clearly the 38% relative risk reduction which is seen in the overall study population, whereas when you take this Asian patient subgroup, the relative risk reduction is very drastic, like it is 56%, very significant. So it is because of the SGLT2 inhibition is more, the better SGLT2 inhibition when compared to the Caucasians. So empagliflozin reduces the risk of first and recurrent cardiovascular events, patients with type 2 diabetes mellitus and atherosclerotic cardiovascular disease. This is inference taken from the empiric outcome, and this is 21% reduction in the risk of myocardial infarction with empagliflozin and placebo. You can clearly see this, and the measured adverse cardiovascular events, that is 3-point MACE, that is the beneficial effects on the 3-point MACE actually. The second thing is the myocardial infarction, or the third thing is myocardial infarction or coronary revascularization. If you see that the one that is favoring the empagliflozin and that favors the placebo, you can see all the patients who are on the empagliflozin, it is these major adverse cardiovascular events as well as the myocardial infarction or the myocardial infarction or the coronary revascularization, they are favoring this particular empagliflozin group. And the additional non-glycemic benefits on top of the standard care, that is why I said pleiotropic. Pleiotrophism itself means not only exerting its the delivered action, on top of it the additional non-glycemic benefits. That's what they said. If we take 100 patients of coronary disease with type 2 diabetes mellitus treated with empagliflozin in 3 years, as seen in empiric outcome trials, the 100 patients with CAD and T2DM in 3 years, we can see the CV events were prevented by 9.8%, and the CKD events were prevented by 8.5%, and the AKI, that is acute kidney injury or acute renal failure, or the hyperkalemia events were prevented by 3.4%, and the insulin requirements were prevented by 12.9%, and additional SBP goals achieved in resistant hypertension was 5.1%. I said in my talk, it is a useful drug in case of resistant hypertension as well as the uncontrolled nocturnal hypertension, whereby the danger hours, that is 2 a.m. to 4 a.m., it is reduced very drastically. The incidence of the heart attacks and the strokes are reduced with the usage of this empagliflozin. And edema and the new onset of obstructive sleep apnea events were prevented by 5.5%, and total additional life years gained were 3.4 years. This is the phenomenal effect, the additional pleiotropic effects which are non-glycemic benefits on top of the standard care which are seen with this empagliflozin. And now this slide shows the empagliflozin demonstrates a meaningful heart failure benefits in patients across the cardiovascular risk continuum. So the CV data, the hospitalization for the heart failure, you can very clearly see the green is empagliflozin and the black is the placebo. You can see all the bars. See the low medium cardiovascular risk with the type 2 diabetes, you can see the difference. That is the risk reduction was 59%, and the atherosclerotic cardiovascular disease without prior cardiovascular events plus type 2 diabetes, you can see the risk is reduced by 31%. ASCVD with prior CV event plus type 2 diabetes, the risk was reduced by 36%, and the heart failure with the preserved ejection fraction plus or minus type 2 diabetes, there was the risk reduction was 17%, and the heart failure with medium reduced ejection fraction with or without type 2 diabetes, it was the risk reduction was 29%. And when you take this heart failure with reduced ejection fraction with or without type 2 diabetes, the risk reduction was 25%. So you can see the all patient groups got benefited with this particular empagliflozin when compared to the placebo. So you can clearly see this the cardiovascular death risk reduction with the SGLT2 inhibitors in T2 type 2 diabetes mellitus, the cardiovascular outcome trials that decreases the risk for cardiovascular death in atherosclerotic cardiovascular disease patients driven by empiric outcome. And this table shows this, it summarizes in patients with type 2 diabetes and atherosclerotic cardiovascular disease, the CV outcomes in the atherosclerotic cardiovascular disease subgroups across the SGLT2 CV outcome trials. CV vote is the empiric outcome that is seen with empagliflozin, that was the canvas that was done with canagliflozin, declared TIMI 58 was done with dapagliflozin, what is CV was done with etogliflozin. You can clearly see that with only all these were very much beneficial with only empiric outcome they were seen, that is empagliflozin only showed the major adverse cardiovascular events were reduced by 14%, CV death by 38%, all cause mortality by 32%, hospitalization for heart failure by 35%, chronic kidney outcomes by 46%. And there is no other comparison for this empagliflozin. The canagliflozin, see you can clearly see there is no significant risk reduction with the CV death, no significant risk reduction with all cause mortality. Whereas the dapagliflozin also, it is the major cardiac, the major adverse cardiovascular events, it was not significant. It was not significant for CV death, not significant for all cause mortality. But as far as this particular the heart failure is concerned, dapagliflozin is a very good the molecule, as well as the chronic kidney outcomes also. And what is CV also similar to the dapagliflozin, but it showed a beneficial effect, though it showed a disappointing effect where it raised the like a debatable issue and doubts regarding the either this particular the effects are the class effects or the drug effects, because etogliflozin literally failed to show the benefits on the major adverse cardiovascular events and cardiovascular death and all cause mortality, but it showed benefits definitely on the two aspects, that is the hospitalization for heart failure and the chronic kidney outcomes. So this is the ADA standard care 2022 guidelines. Okay, they say that after metformin the essence I'm going to summarize, because see, after metformin, to start with, the treatment of type 2 diabetes starts with a lifestyle modification, that is diet and exercise. And there is a comprehensive term called therapeutic lifestyle changes, that is diet, exercise, reduction in the weight, cessation of alcohol, cessation of smoking. So this is the cornerstone of the any chronic or the lifestyle disease like diabetes, hypertension, dyslipidemia, or the heart attacks or the strokes. So one has to abide by all these things. First, diet, exercise, reduction of weight, cessation of smoking, cessation of alcohol. After that only the drugs come into play. That is, we start with metformin unless otherwise it is contraindicated. On top of it, the patient is at risk of atherosclerotic cardiovascular disease or already has that particular atherosclerotic cardiovascular disease. What ADA says, what EASD said. EASD was the first governing body, international governing body, that said way back in 2019 itself, European Society of Cardiology said that the patient, drug naive patient of this, particularly the type 2 diabetes patient, comes with either at risk for atherosclerotic cardiovascular patient disease or the established atherosclerotic cardiovascular disease. With or without metformin, you can use the GLP-1 receptor analogs, that is the liraglutide or the semaglutide or the dulaglutide. If the 3-point MACE predominates, or you can use the SGLT2 inhibitors if heart failure predominates, with or without metformin. See, that is the first international body that endorsed this particular the SGLT2 inhibitors and the GLP-1 receptors, or the combination of both. And later on, the EASD, that is European Association for the Study of Diabetes, later on joined hands with the EASC, that is European Society of Cardiology, and has came out with the common consensus actually, and that was the ESC bar EASD common consensus for the treatment. They said the same thing, and of late from 2021 and 2022, ADA started saying in its the every year in the month of December itself, we get the guideline, the recommendations, the standards of care for diabetes from American Diabetes Association. That is the first January edition of diabetes care contains nothing but the recommendations. They don't have any articles. All the recommendations are seen only in the January volume of that particular diabetes care for that particular year. So this is the essence. It says after metformin, you can use either the SGLT2 inhibitors or the GLP-1 receptor agonists. That's what this. And to summarize actually the take-home message, okay, the empagliflozin and the holistic cardio-renal metabolic care in people with type 2 diabetes and atherosclerotic cardiovascular disease. And on the left hand side you can see the risk factor control, on the right hand side you can see the target organ protection, effective HbA1c control and metabolic control that decreases in the risk of major adverse cardiovascular events and the lower risk of hypoglycemia. This is the greatest beneficial point that is to be noted with this particular empagliflozin. It reduces the HbA1c very drastically without any hypoglycemia, and it is a beta cell independent mechanism, and improvement in time in range, that is very important. That is the glycemic variability is very much reduced, which increases the blood sugar levels. That's it. And the reduction in the adiposity and inflammation and blood pressure, and improvement in the insulin sensitivity. The target organ protection we see in the form of the reductions in the risk of major adverse cardiovascular events, and the reductions in the risk of cardiovascular death, reductions in the risk of heart failure events, reductions in the risk of kidney disease, reductions in the hepatic fat and NAFLD outcomes as well as the NASH, and reductions in associated risks like OSA and CAN, that's what, and also the reductions in the vasovagal syncope, and the table has not mentioned that it has got a very good role in reducing the hyperuricemia. There are so many things, the positive things which are not dependent on only glycemic control, and this is beyond glycemic control. We see lot of additional beneficial features either in the patient suffering from type 2 diabetes or in the absence of type 2 diabetes, and empagliflozin is a wonderful drug of molecule. And with that, I think I conclude my talk. Yeah. So if there are any questions in the chat box, please. I request Kishore. Hello.
Sir,
Yeah.
definitely I would say it is a fantastic and fantabulous presentation.
Okay. Thank you so much. Thank you.
You covered each and every point, each and every line
Yeah.
on the slides.
Yeah.
There in the topic, it is fantastic.
Thank you so much, Kishore. Thank you. Are there any questions in the chat box? Let us take up the questions.
Yes, sir. Yes, sir. So far there is no questions
Okay.
in the chat box, sir.
Wonderful.
We'll wait for another 30
Okay.
seconds.
Okay.
So after that we can close the meeting.
Okay.